Good afternoon everybody. I think what we will do today is talk about antithrombotics in clinical practice. So we will see what antithrombotic to use, why to use and where to use. So please understand that in cardiology and also in medicine, in this particular area, vascular area, there are three issues at stake. When we are choosing a drug, we have to look at three things and then decide, depending on requirement, which drug to use when, looking at these three issues. So number one is of course ischemic risk. So that we know is a very important factor in cardiology and many other places also. In any vascular disease, ischemic risk is there. The other risk that is present is the stroke risk. And for example, in atrial fibrillation, we are worried about stroke risk. We are not worried about ischemic risk. But when we are talking of coronary artery disease, then we are worried about ischemic risk. But whatever drug we use, there is a finite risk of bleeding. So these three things are interacting. So any medicine we use, if we use aspirin, we have to understand how much ischemic risk it reduces, how much stroke risk it reduces, but how much bleeding risk it can cause. If you look at, let us say, clopidogrel, again we have to look at how much ischemic risk it prevents, how much stroke risk it prevents and how much bleeding risk it causes. Then depending on the situation, you choose a drug. So ischemic risk is what? It is arterial thrombosis risk. So that is ischemic risk. So wherever there is artery, there is a possibility that there could be a formation of thrombus, and that risk of formation of thrombus is the ischemic risk. So the artery is there in coronary, it is there in brain, it could be there in renal, it could be there in muscle, it could be anywhere. Wherever artery is present, there is a risk that clot or thrombus can form inside the artery, and that risk is known as the ischemic risk. Now the second kind of risk is interesting, and that is the venous risk. Wherever there is vein, there is risk of formation of a clot, and once the clot formation in the vein, that clot can go from right side to left side, and from left side it can go into brain. So that is the stroke risk. So understand that ischemic risk is arterial risk, but a stroke risk is a venous risk. So that is why if you want to prevent arterial risk, you would use a different kind of drug which acts and reduces the arterial thrombosis risk. But if you want to prevent the stroke risk, then you choose a different kind of agent that will prevent thrombus formation in the vein. Like for example, deep vein thrombosis is thrombus formed in the vein. Like for instance, pulmonary embolism is a thrombus formed in vein, because it is from the right side, although it is pulmonary artery, but it is from the right side. So it is a venous kind of. Stroke risk also, although it is in the brain, but it is because of this right to left thrombus migrating from the venous chamber. So in LA is also, it is considered a vein, because left ventricle, from left ventricle the arterial system starts. So left atrium is also considered a part of venous system in this paradigm. So that is why any clot formed in left atrium because of mitral stenosis is also considered a venous risk, and therefore the drugs to prevent that clot formation are different from drugs that will reduce the arterial clot formation. So I think this is very important to understand the beginning. That is why you see some drugs are effective in prevention of strokes, but that same drug may not be that much effective in prevention of angioplasty or in other situations where there is a stent thrombosis or other arterial side of thrombosis risk. So that same drug may not be very effective there. So you have to choose a different drug. But whether it is reducing ischemic risk or whether it is reducing the stroke risk, both these drugs can increase the bleeding risk. So depending upon how much risk you are facing, if you are facing a lot of risk of ischemic thrombus, then perhaps you have to use a very strong agent. So using that strong agent may increase bleeding risk more, but then you have to balance the risk of ischemia with the risk of bleeding, and if the risk of ischemia is high, then you use more potent agent to reduce the risk of ischemia. But if the ischemic risk is low, then you are worried about bleeding risk. So you use a lower potency agent so that you can have lower bleeding complications. So depending on situation, and we will come to that, you choose your agent. But remember, this is for prevention of clot formation. What we are talking here is prevention of clot formation. There are another set of drugs which are useful once the clot has already formed. So if pulmonary embolus has happened, if arterial thrombosis has already happened, heart attack has already happened, then there may be a point in further prevention of heart attacks, but this heart attack you have to treat differently, because you can't choose only prevention drugs, you have to use drugs which will dissolve the clot. So therefore this is prevention and this is treatment. So in the treatment, obviously you have 2 or 3 kind of options. Suppose the clot already forms, then what to do? So you can dissolve that clot giving some drugs that will dissolve the clot, and those drugs can be streptokinase, which was discovered from streptokinase was a streptomycin bacteria. So that was a streptokinase. This is another drug is TPA, tissue plasminogen activator, which is genetically derived agent. By genetic engineering you can get TPA or TNK, which is also a specific agent, which is a tissue agent. So difference between streptokinase and these tissue agents is streptokinase can act all over the body. So what it will do is not only dissolve clot that is formed in tissue, but it will dissolve clot anywhere. So because it has got a more widespread action, the risks are higher. That is why streptokinase have more intracranial bleeding risk, because it will dissolve clot everywhere, whereas tissue plasminogen activator is specifically active on the tissue where the fresh clot is formed. So that is why we have moved over from streptokinase to TPA, because number 1, TPA is more safer, number 2, because it is acting specifically against the tissue clot formed, it is more effective also. So it is not only more effective, but also more safe. So previously we were using streptokinase, now we have moved into these tissue agents, because they specifically act at that particular site. But in many cases clot may be so high that it may not get dissolved by these drugs. So then you have to do some mechanical thing. So one mechanical thing could be doing angioplasty. So you cross the clot, inflate the balloon, deflate the balloon, clot gets crushed and it gets dissolved by already thrombolytic mechanisms that are present in the body, and then you can take care of that clot and then you can do. So the one option could be doing angioplasty, other could be there are devices where you could directly extract thrombus. So you go where the thrombus is formed, take that device, it's like maybe could be like a basket, and you inflate the basket below the clot, pull the clot out, or there can be other devices. So there can be many devices of thrombus extraction. You could suck the thrombus, you could take your catheter, you could suck it. So that is also thrombus extraction. So various ways of removing clot. The other thing is, what can clot do? The problem is that clot can go distally and block the microcirculation. So you put a distal protection device, and meanwhile, so that the clot doesn't block the peripheral bed, meanwhile clot it will get dissolved over a period of time. So then you can also use this particular kind of device. This is distal protection device. So my idea of telling you at this slide is that you have to understand that one is prevention of the clot, second is the treatment of clot. Coming to prevention of the clot, you have to see where the clot is forming, whether it is the arterial clot forming or venous clot forming. But always keep in mind that all these can have a bleeding risk. But once the clot has formed, these drugs will not help that much. What they will do is, once the clot is formed, you take care of this clot, they will prevent further clot formation, but they will not treat the clot that is already formed. So for treating the clot that is already formed, you might have to use either drugs or you might have to use some mechanical device. So, coming back to the same thing, that all these drugs can have bleeding risk. So, because we are talking to medicine people, I wanted to tell you which are the drugs that have got a bleeding risk, because if you use these drugs along with some of these agents, then bleeding risk may increase multifold. So, when you are using these drugs in your clinical practice, you have to also remember what are the interactions with other drugs which can increase the bleeding. So, there is this acronym A-pinch. A is for anti-infectives. So, there are many anti-infective agents which can increase the bleeding risk. P is for potassium and electrolytes. I is for insulins. N is for narcotics. C is for cytotoxic agents, and H is for heparins. So, these are basically high risk medicines. They may not necessarily cause bleeding, but these drugs you have to be very careful. So, what I was trying to tell you is that number one, you need to know which drugs interact with heparin and these agents. The other thing that I wanted to tell you is you make a list of drugs that have got lot of side effects. So, this A-pinch is for those drugs that have got maximum side effects. So, whenever you are using these drugs, you have to keep in mind that side effects can happen. So, A-pinch, anti-infectives, we know a lot of side effects. If you give high dose of potassium, you can actually cause bradycardia and even cardiac arrest. Insulin, if you give high dose of insulin, then there can be severe hypoglycemia and people can die. Likewise, narcotics, of course, we know that narcotic overdose can happen, and cytotoxic agents are cytotoxic by definition. So, these are all the high drugs which have got safety concern with them. So, whenever you are using any of these drugs, and heparins and anticoagulants belong to same group of drugs because they can cause lot of bleeding. So, they are basically potent medications, narrow therapeutic window, more likely to cause harm if you have error in dosing or something. So, all these drugs, they can have multiple interactions, they have complex dosing and monitoring schedules, and they have wide variation in effect. So, these are something which are common for all these drugs. Not necessarily, I do not mean that these drugs can cause bleeding. What I meant was they can cause some side effect, and as a medicine practitioner, whenever you are using these drugs, you have to be very careful that correct dosing is going and correct indication is there. Because if you do a wrong error on this, then this can cause life of the patient. Now, coming to ischemic risk, as I said, ischemic risk means arterial thrombus formation risk, arterial thrombosis risk. So, what are the situations where you have risk for arterial thrombosis? So, that is why when you identify those areas where there is risk of arterial thrombosis, you can use these anti-ischemic drugs. More importantly, you have to classify how the arterial risk is increasing of thrombus formation, because if you can identify how the thrombus risk is increasing, you can give more potent medication. So, that is why. So, simplest, lowest risk, stable coronary artery disease, acute coronary syndrome, higher risk than stable coronary artery disease, MI, acute ST elevation MI, even higher risk than acute coronary syndrome of forming of arterial thrombus. Then whenever you do angioplasty, risk is still higher of formation of thrombosis. When you put a stent, then risk even higher than just plain angioplasty. If you put a complex PCI with many stents and complicated case of PCI, then the risk is even higher. But if you have two of these things together, so for example, if you have PTCA in acute MI patient, then the risk is the highest. So, you understand how the risk is increasing. As you go down, the risk of arterial thrombosis is increasing. So, here stable CAD, maybe you use just aspirin, simple aspirin is okay. Acute coronary syndrome, maybe you want to use a dual antiplatelet therapy. So, you want to use aspirin with clopidogrel, dual antiplatelet therapy. Suppose you have myocardial infarction, then you use aspirin but use more potent agent, more potent than clopidogrel. You might want to use a prasugrel or ticagrelor. If you are using PCI with a stent, PCI with POBA, then use more potent agent. If you are putting a stent, then when you are putting a stent, not only you use these two agents, but you may even start heparin. So, this is the third agent that you are using, because you know that at the time you are doing angioplasty, the risk is high. So you might even add heparin. So you understand that as we go down, we keep on adding more potent agents, and we can keep on adding more agents to prevent arterial thrombosis. So this is, we are talking of arterial thrombosis. Now coming to stroke risk, which are the situations where stroke risk is higher? Because then we have to use a different group of agents. Aspirin, for example, reduces arterial thrombosis, as well as little bit effect on venous thrombosis also. So for even venous thrombosis, you could use aspirin, although there is now controversy. Now people think that it is not much effective against venous thrombosis. That is why you have to use other agents. But previously people thought that even aspirin can be useful, and it does have some venous, anti-venous thrombosis effects. So, but the risk, if you look how it increases. So coronary artery disease, while it has got high arterial thrombosis risk, but it also has some venous thrombosis risk. So even coronary artery disease has some venous thrombosis risk. That's why if you use aspirin, you can take care of both arterial thrombosis and little bit of venous thrombosis risk also that CAD might have. But if you go down, if you have a knee replacement or any surgical procedure where you are lying down, then the risk of venous thrombosis increases. If you have non-valvular AS, then the risk is even more than just lying down in bed, sick patient lying down, immobility. But if you have a non-valvular AF, then the risk is higher. But if you have valvular AF with severe MS, then the risk is even higher than non-valvular AF. So now you see how the risk is going on increasing. This is venous risk we are talking of. Then if you have a bioprosthetic valve early on, then risk is even higher than plain MS with AF. But if you have a mechanical prosthetic valve, then you have long-term higher risk of venous thrombosis. So you have long-term higher risk of venous thrombosis. But if you have prosthetic heart valve with AF, then you can imagine that there are two factors causing increased risk, and then the risk is the highest. Prosthetic heart valve, particularly mechanical prosthetic heart valve with AF, that has the highest risk. So again, what it means is that maybe very small risk you could take care with just aspirin. But if you come to prevention of venous thromboembolism, non-valvular AF, then maybe you have to use some drugs. Maybe you have to use warfarin, you have to use continuous heparin or acetrom or NOACs, which are the new drugs. I will come to that. So maybe you have to use NOACs. But if you have AF with severe MS, then maybe NOACs, novel and oral anticoagulant agents may not be enough, and you may have to use warfarin or heparin or acetrom, something like that. If you have AF with severe MS, if you have AF without severe MS, then maybe NOACs may be enough. But if you have AF with severe MS, maybe NOACs are not enough, and you may have to use more potent agent, which could be warfarin, acetrom or continuous heparin if possible. Then bioprosthetic valve also, that is why for 3 months, even with bioprosthetic valves, we either put them on acetrom or warfarin or continuous heparin, because this is higher risk. So you can't just rely on aspirin or nothing. You have to give something to prevent venous thrombosis. But if it is mechanical prosthetic valve, the risk is even higher. And so maybe lifelong you have to give warfarin or something like that. But here you cannot use NOAC, because NOACs are not that strong as warfarin or acetrom. So you can't use NOACs here in mechanical prosthetic valves. You will have to use either warfarin or acetrom. And also obviously again, if AF is also present, so obviously you have to use even more potent agents. So again, I think the idea what I wanted to tell you was that as the type of thrombosis and the severity of the thrombosis decides the type of anticoagulation that you are going to use, or type of the antithrombotic agent that you are going to use, and the duration of that agent also. Because if the risk persists lifelong, then you have to use lifelong. If the risk goes away, like in bioprosthetic valve, after 3 months the risk decreases. So then you don't need to give heparin to this person, or don't need to give acetrom or warfarin to this person after 3 months. So you can discontinue. But when mechanical prostatic valve is present, maybe you have to continue lifelong. Clear this part? Now the question is, why there is a risk of a stroke after venous thrombosis? So we know that blood is usually sluggish in the venous chambers. Top of the heart atrial part, I also told you, is considered venous for our point of view, and this can lead to formation of blood clots. The most common site, whenever you have a stroke, the most common site of clot formation is left atrial appendage or left atrium, left atrial appendage. Every kind of a stroke, echo is mandatory, because you have to rule out a left atrial appendage clot or a left atrial clot. That is why echo is mandatory in all cases of a stroke, because you don't know whether it is coming from, because that is the commonest site where the venous clot arises. What happens with AF? When AF happens, then heart is irregularly contracting. So if something is regularly contracting, you can attach to it, but if somebody is contracting like this, then there is a chance of clot dislodgement. That is how AF causes this thing, CVA, because what AF does is irregularly contracts. So there is a risk of dislodgement of clot that is already formed in left atrial appendage or LA, and that is why AF increases the risk of venous thrombosis. And obviously this then clot travels to brain and can cause a stroke. So this is it. So question is how to reduce. Now let us look at one by one. How do we reduce the arterial risk? How do we reduce the venous risk? So here is a sort of demonstration of the arterial thrombotic pathway. So this is, I think all of you know that this is how it happens whenever there is platelet activation which forms the thrombus, because thrombus is platelet activation. So platelet activation can happen by various mechanisms. One is that there is formation of collagen, thrombin, thromboxane A2. Whatever this is the ADP dependent pathway, then it causes activation, ADP activation, and that leads to the final common pathway, that is GP2B3A. So GP2B3A is a site where this thrombus formation happens. So it's that actual part where this thrombus will fix, and that particular part is GP2B3A in the cell. So every cell has got this, particularly the platelets have got this GP2B3A receptor, and this is the final common pathway. So if you can block this pathway, then you can prevent the clot from forming. So that is why, you know, so this is one pathway. The other pathway is, one is ADP pathway and the other is thromboxane A2 pathway. So these are two pathways, and this is the COX pathway which can lead to this final common pathway. So activation can occur either through ADP pathway or thromboxane A2 COX pathway. So obviously if you use two types of things, so either you use ADP inhibitors, which is clopidogrel, ticlopidine, prasugrel, ticagrelor. So they act through the ADP pathway and they can block. Now obviously you have to understand that if you use clopidogrel or ticlopidine or prasugrel, ticagrelor, you are blocking only the ADP pathway. So 100% clot formation you cannot reduce. Understand this, because it will block only one pathway. This COX pathway, this pathway is still active. So some activation will happen through this and some clot formation will happen through this. But how do you block this pathway? You give aspirin. So while clopidogrel, ticlopidine, prasugrel, ticagrelor block ADP pathway, aspirin blocks this thromboxane A2 pathway. So if you have to have a more effective blockage of this pathway, you have to use both these agents, ADP blockade as well as thromboxane A2 pathway blockade. So you use dual antiplatelets, aspirin plus one of these agents. So you could use aspirin plus clopidogrel, aspirin plus ticlopidine, aspirin plus prasugrel, aspirin plus ticlopidine. So this is DAPT, dual antiplatelet, because you want to block both the pathways, the ADP pathway as well as this COX pathway. But suppose you want to block the whole thing, then you have to block the final common pathway. This is the GP2B3A receptor, GP2B3A receptor, and that is the final common pathway. So you use GP2B receptor antagonist, then you can block, irrespective of whether these pathways are blocked or not, it will block the thrombus formation. Unfortunately, problem is these drugs are IV drugs, so you cannot give them orally. So sometimes in complex angioplasties, you use aspirin, you use one of these agents, ADP blockers, but if the thrombus load is high or you think lot of thrombus formation, lot of thrombotic risk is there, then you might have to give infusion of GP2B3A inhibitor. So here you may be using 3 arterial thrombosis drugs to prevent this clot formation. So that will happen especially if you are doing angioplasty on high risk patients like either acute MI with complex lesions. So there you might want to give along with dual antiplatelets GP2B3A inhibitors, because the risk is highest. If you remember that chart, that list I showed you, the risk is highest here, complex angioplasty, and there you might have to give the 3 agents. So I think this is clear. Problem is the more agents you add, the more bleeding risk increases. So if you use only aspirin and you block only this pathway, as you do in stable coronary artery disease, then the bleeding risk is lowest. But if you have myocardial infarction, then you want to block both the pathways, so you use dual antiplatelets, and then the bleeding risk will increase. But if you are doing complex angioplasty and you are adding this and this and this also, then the bleeding risk is highest, and so very, very high risk of bleeding in those cases. So as you understand that as the indication changes, you add more and more drug, but at the same time the bleeding risk keeps on increasing manifold, depending on how many agents you are adding or what type of agent you are using also. Now coming to aspirin, so first drug antiplatelet agent or first antithrombotic agent in 1974, it was found, RCT was also done, and it was found that it can prevent mortality after myocardial infarction if you give aspirin. It's a very simple trial, and it showed that about 25% of mortality reduction can happen only if you give aspirin. So as I told you, classically what happened was, in a heart attack patient, before all this era, it was found that heart attack patient had 10% mortality at the time of presentation, 10% mortality in hospital, and 10% mortality within 1 year. So overall within 1 year, 30%, 1/3 of the patients of heart attack died. With aspirin what happened was that this mortality became half. So from 30% it came down to 15%, just with aspirin, just one drug. It could reduce the mortality by 50%, or it basically it brought in less than 20% or less than around 10% it brought the mortality with this. So this is some of the RCT which showed that there could be a huge mortality reduction. Now this acts through, aspirin acts through COX-1 pathway, I showed you that, but this is in bit more detailed, that membrane phospholipids are there, arachidonic acid is there. Once arachidonic acid, it leads to formation of prostaglandin H2 and thromboxane A2, which is a platelet aggregator, and prostacyclin, which decreases, but more effectively it increases thromboxane A2. So this is a thromboxane A2 pathway or COX-1 pathway. So to prevent the formation of thromboxane A2, which happens in whenever this arterial thrombosis mechanism is activated, if you can add aspirin, it is a COX-1 inhibitor, and it will block this, and so less thromboxane A2 will form, and therefore less platelet activation. So this is how aspirin works. Other than its anti-headache effect and other fever effect, it has this action of blocking COX-2, which is an important enzyme in this conversion and formation of thromboxane A2, which is a potent platelet aggregator. So, platelet aggregation will stop, and that is how aspirin can work. But then what happened was that some trials came, and this trial showed you that this clopidogrel, which is effective on another pathway, ADP dependent pathway, you remember, it is slightly more effective than aspirin in reducing the risk associated with coronary artery disease, and the risk associated with coronary artery disease was stroke, MI and peripheral arterial disease. So, these were the risks associated with coronary artery disease patient. As I said, coronary artery disease patient is also a higher risk of stroke. So, aspirin was reducing all these three risks. It was reducing the stroke risk, it was reducing the MI risk, and it was also reducing the peripheral arterial disease risk. But clopidogrel was doing more than aspirin. So, clopidogrel is a more effective agent. So, if you use one agent which is more effective, then probably out of aspirin and clopidogrel, maybe you would choose clopidogrel. That is why a lot of people now are using clopidogrel as a single antiplatelet agent in coronary artery disease versus aspirin. Some people are still using aspirin because it is very cheap, but some people are not very comfortable with aspirin. They want to use a more potent agent even in stable coronary artery disease, and they are using clopidogrel. But problem with clopidogrel is one, that there is something called clopidogrel resistance, that clopidogrel is not effective in 100% of the cases. So, it may be, there may be a percentage of cases where clopidogrel does not affect or is not active. So, it is like if you give clopidogrel to those people, it is like not giving any antiplatelet agent. So, that naturally they will have arterial thrombosis because you have not given anything to them. But problem is you do not know which people will have this resistance and which people will not have this resistance. Now, this value of resistance is also varies widely from studies. Some studies say 5%, some studies say 30%. So, depending on different populations, the clopidogrel resistance happens. So, that is why very serious cases like, for example, heart attack or acute coronary syndrome, you cannot rely on only one agent. Aspirin, as you know, is not very effective. Clopidogrel, some cases can have resistance. So, if you combine these two drugs, then at least you hope at least one will work. And that is why in acute coronary syndrome or acute MI, you use dual antiplatelets, not only to increase the effect, because both act through different pathway. So, if both are effective, then the antithrombotic effect will be higher, but even if one is not effective, at least the other drug will be effective. So, that is why benefit of using dual antiplatelets. So, that is one. So, this is, you see that clopidogrel, this was the standard dose, and in some cases there was a clopidogrel resistance. If you increase the dose of clopidogrel, then to some extent you can take care of this resistance. So, one way is that instead of using low dose 300 mg, you can use a higher dose 600 mg. Instead of using 75 mg, you could use a higher dose of 600 mg, and you could see that if you double the dose or very high, it improves, but not statistically significant. So, there is some benefit, but maybe not that much even of increasing the dose. So, why does this happen? Why is there resistance with clopidogrel? Because now if you look at metabolism of clopidogrel, clopidogrel gets metabolized into these two agents. This is pro anticoagulant agent, again it gets converted into the third agent, and that third agent is, this is the real anticoagulating agent or antithrombotic agent in clopidogrel. So, clopidogrel by itself is not antithrombotic, it is one of its metabolite, second degree metabolite is the one that is really antithrombotic. So, clopidogrel has to get converted first into this oxoclopidogrel, and from oxoclopidogrel it has to get converted into clopidogrel AM, and clopidogrel AM is the one that is actually antithrombotic. So, if there is some problem in metabolism, and that is what happens in clopidogrel resistant patients, that there could be some problem in metabolism, that this metabolite is not formed, and once this metabolite is not formed, then actually there will be resistance to the effect of clopidogrel. So, this is one reason that clopidogrel undergoes 2 conversions before active moiety is obtained. So that is why you understand now increasing dose will also not help, because that metabolite is not happening. There is some problem in metabolism of clopidogrel, and that active metabolite is not forming, and therefore increasing dose is not that much helpful. So what to do? So you can use another agent which has got a higher efficacy. So prasugrel is that agent that has got more efficacy. And also remember these trials. This is the Triton-TIMI. Go back. So this is the randomized control trial of acetyl. This is one classic trial that you should need to know. Next, remember the name of these trials also. This is the Capri trial. So you might be asked in exam, which trial has shown that clopidogrel is better than aspirin? And that trial is Capri trial. Then a question will be asked that which trial has shown that prasugrel is more effective than clopidogrel? Come to the next. And this is Triton-TIMI 38 trial. So just keep in mind some trials also. And this trial, what it did show was that if you used prasugrel, then the benefit was higher, and prasugrel led to better reduction of ischemic risk. The problem was that bleeding risk was much higher. So prasugrel reduces the ischemic risk. So this is the risk of cardiovascular death, MI or stroke. This is the ischemic risk. Once you use prasugrel, nearly the half the risk. So more, but it means it has got double efficacy than clopidogrel in reducing the ischemic risk. It reduces the ischemic risk to half. So if the ischemic risk was, let us say, here it is like 12%, then it is like only 6% ischemic risk. So it is very potent antithrombotic agent. It highly reduces the ischemic risk. The only problem is it does it at the expense of higher bleeding risk. So as I told you, but if you need sometimes, suppose you are doing primary angioplasty on acute MI patient. So there, because of MI, the thrombotic risk is there, and you are doing angioplasty, the thrombotic risk is there. So twice the thrombotic risk. So you require a more potent agent. So naturally, you might have to think of using a more potent agent, something like prasugrel, which is more effective than clopidogrel, and accepting the side effect of bleeding, because there could be some increase in bleeding risk with this particular combination. Next, but still the search goes on, and a newer drug has been identified, and that is what? Ticagrelor. Now benefit is, the problem with prasugrel was that bleeding risk was very high. So we required a drug where thrombotic action was better, but bleeding risk was not that high. So this drug was identified, ticagrelor, and remember this trial plateau study, which showed you that compared to clopidogrel, ticagrelor was better in reducing the ischemia or thrombotic risk, but with no higher rate of bleeding overall. So it was more effective than clopidogrel, but not much increase in bleeding risk. So a balanced drug of the two. So at one hand, prasugrel very potent antithrombotic, but much higher bleeding risk. Clopidogrel much low bleeding risk, but much higher thrombotic risk. Here comes ticagrelor, which is much higher effective in reducing thrombotic risk, but with lower bleeding risk. So that is why ticagrelor become more useful. Next. So it was better and safer. So here is the comparison between the efficacy, and you can see comparison of all the three components. What you will notice is that all these drugs, even aspirin, clopidogrel, prasugrel, also have some anti-stroke effect. So you keep in mind that all these drugs, while they are predominantly effective against arterial thrombosis, they have some effect in reducing the venous thrombosis also. So aspirin has the lowest arterial thrombosis risk reduction, clopidogrel is higher, prasugrel and ticagrelor are still higher, prasugrel even more higher than ticagrelor, but minor improvement in thing. But if you look at bleeding, then you see aspirin has the lowest bleeding risk, clopidogrel has higher bleeding risk, prasugrel has the highest bleeding risk, versus ticagrelor, which is balanced, good ischemic risk, with little bit higher bleeding risk. So, ticagrelor seems to have a balance of safety and efficacy, and this is the comparison of all the three areas: ischemic benefit, stroke benefit, and bleeding risk benefit. Also, what we understand is that the ADP pathway, that is clopidogrel, ticagrelor, prasugrel and teclopidine, is more effective agent, but at a bit higher bleeding risk. So, this I think we will cover tomorrow. So, this is today we have covered arterial thrombosis. Tomorrow we will cover the venous thrombosis. So, that is like reduction of stroke risk, DVT and other